have and their thought processes. So if you're presented with a patient with acute loss of vision, can some people put forward some possible things that go through your mind, possible diagnosis to entertain yourself? So, Labib, can you think of anything? You talked about transient loss of vision before.
Could it be part of sort of a wider transient ischemic attack?
Yes, yeah, I mean, that's one possibility. And then eye diseases in themselves. Can you think of eye problems?
So could it be sort of secondary to trauma when you get a complete detachment of the retina?
Yeah, retinal detachment, that's a very important cause.
You stole my one, Labib. That's what I was going to say. I couldn't get there fast enough.
Who's that?
Hannah.
Hannah.
So yeah, I'd say something vascular for anything sudden. And yeah, retinal detachment is always the one that comes to my mind.
Yeah, there's a lot of vascular causes. Anything else? Is Mary there? I hear she's supposed to be coming to us. Mary Sisley? No.
Hello, yes, I'm here.
Sorry. Have you got any suggestions, possible diagnosis?
Can you tell him I've cut out?
Okay.
Oh, no, I haven't cut out.
No, we can hear you.
Sorry, I'm having a bit of Wi-Fi trouble.
Okay. Anyhow, well, when I was preparing this talk, I came up with 20 plus things. This is my notes, just preparing it. And I think if you're presented with a patient, it's something that you should have a structure to working out what's going on and think anatomically from the lids and orbit, cornea, front of the eye, iris, going back to the retina and the brain. And obviously you're going to take a history and you want to find out how sudden, how acute is this problem. Maybe it's a chronic underlying problem that's got worse. They may have a history of macular degeneration and suddenly it's got worse and they've lost the vision in that eye that was already struggling. Is it unilateral or bilateral? Bilateral would suggest something neurological. You're unlucky to get simultaneous problems affecting both eyes at once. You wouldn't get acute glaucoma very rarely in both eyes. You want to clue in, think carefully about what symptoms the patient is telling you about. Are they getting headache, temporal headache? Is it giant cell arteritis? Have they got halos around lights at night? That's a symptom of acute glaucoma. Photophobia, sensitivity to light with iritis. We're going to talk about all of these. Floaters, a lot of patients have floaters that are long-standing, but if they have increased floaters in their visual field or flashing lights, photopsia, or a shadow come across the vision, then you think about retinal detachment. Distortion is a symptom that happens with macular disease, and double vision is a sort of ancillary symptom. Doesn't cause loss of vision, but it gives you a clue what might be going on. Then you need to check the visual acuity. I've got a separate slide on that, just on its own. That is the most crucial thing. If you're presented as a GP or working in A&E with a patient with loss of vision, if you haven't tested the visual acuity and recorded it, you are in big trouble if anything gets missed. That's the first duty of care, is to record the vision. You want to look at the pupils, how they react. We'll talk about doing an afferent pupil defect test, a swinging light test. If you've got an afferent pupil defect, that tells you it's a serious problem. It's either retina or optic nerve. Then you want to have your structure looking at the front of the patient, looking what clues there are in the lids and orbit. Is there proptosis? Is it all inflamed, erythematous? And then you've got to have some way of looking at the anterior segment and dilating the pupils, looking for the red reflex, the optic disc and the retina. Intraocular pressure for acute glaucoma There are some gadgets, instead of having to use the slit clamp Goldman tonometer, there are portable gadgets that you may have access to. But in acute glaucoma, when you just do digital palpation, the eye feels rock hard, and just comparing it to your own eye and the patient's eye, you'll notice a definite difference. It's not very difficult to find that. Here we go. So these are the things you would like. Snellen chart of some sort. You could probably do it on your phone with an app. You want a magnifying lens. If you haven't got a slit clamp, then you want some sort of lens and a torch looking for corneal ulcers. If the patient's difficult to examine, putting in anesthetic drops helps. And then if you can't see what's going wrong on the front of the eye, you need to check that it's not a problem with the posterior segment, the retina or optic disc. So you need to put in a dilating drop. So a slide about visual acuity, we've talked about that. Looking at the pupils, before you start, you've got to get the patient looking into the distance. And while they're looking at the distance, you should look at their eyes and see, is there a ptosis or any other abnormality? Get them to focus on a distance object so they're not accommodating and confusing the results. And you want fairly low lighting in the room to see a discrepancy between the reaction of the pupils. And you do this swinging light test, shining on one eye and then the other, backwards and forwards. And if the pupil starts to dilate, then that is equal to a relative afferent pupil defect. And that's a serious sign to pick up on. So dramatic reduction in vision and a pupil defect are things to pick up on that it's a serious problem. So in that slide A, the right eye, the pupil is constricted, but then you swing over to the left and it's slightly dilated. And you do that backwards and forwards, and then it becomes more apparent. So this is a patient I saw a long time ago when I started here in Eastbourne, and she came in to hospital not able to open her eye, and she was toxic. She was all flushed, pyrexia, and she had orbital cellulitis. And this is a child also with cellulitis. Sorry, jumping around a bit. And you can see the CT scan here showing an ethmoid sinus infection which has spread into the orbit. The important thing about cellulitis is to determine whether it's preseptal in front of the septum here. I don't know if this pointer is working, but the blue line, this separates the orbital contents from the skin and muscles. So if you've got an infection behind the septum, you get sort of pressure building up. You get paralysis of the ocular movement, so they can't move their eye and they get double vision. The worrying thing is that there's compression on the optic nerve and they can lose their sight easily if it's not treated quickly. Also, it can spread and cause meningitis. So the orbital septum decides whether it's orbital or preseptal. If it's preseptal, it's usually something like an insect bite, and there's no proptosis, there's no loss of vision, the pupil should react normally, they have full range of eye movements, and it's localized to the skin. This is a busy slide. Basically, this is the up-to-date guidelines for treating preseptal and orbital cellulitis in the Trust. These were just ratified, but they should be on the Trust website. Any questions? No. Right, so I'm going to ask a question here. There are two patients here with some clinical signs. The one on the left, what do you think the diagnosis is? Labib.
Conjunctivitis.
Yeah, she's got a conjunctivitis, but it's secondary to something. This is the lady on the left.
Shingles.
Yes. Who said that? Well done.
Hannah. Hi.
So you can see there's a demarcation line obeying the midline, and she's got scabs and ulceration. Then the one on the right, that's got conjunctivitis. But what do you think the cause is? If you look, I don't know if you see my pointer, but by her nose there's this lump, and that's the mucocele. So that's the lacrimal sac is blocked and it's full of pus, and that can get infected and cause cellulitis. So with shingles, I'm sure you all know it's related to the chickenpox varicella virus. They get very unwell, and they're elderly patients, and they can get dehydrated and confused with this. Also, you see that with acute glaucoma, and it's a very painful condition. There's this important sign called Hutchinson's sign, which is they've got a vesicle on the tip of the nose that's supplied by the nasociliary nerve, which also supplies the cornea and other parts of the eye. And it's a predictor that they may have serious eye problems. And herpes zoster can cause no end of problems within the eye. You get a keratitis, you can get secondary glaucoma, uveitis, optic neuritis, you name it, vitritis, and a retinitis. So these patients need to be seen by ophthalmologists. The important thing is to start them on oral acyclovir without delay, because that reduces the chances of them getting post-hepatic neuralgia. Now, talking about trauma, which is important, and a lot of you identified this as an acute loss of vision. Things, there can be bleeding and trauma to the structures of the eye, and one sign of it doesn't preclude other problems. So you need to do a full examination. So if you get bleeding in the front chamber, the anterior chamber of the eye, you get a high femur. That can cause glaucoma, secondary pressure rise in the eye, but you've also got to make sure they haven't got a retinal tear or vitreous hemorrhage, and so on. One of the most serious things that could happen is they could get a bleed behind the eye in the orbit, and this causes a sort of a compartmental syndrome with pressure on the optic nerve, and also the intraocular pressure goes up, and you can lose your vision quite quickly. The patient, it's obvious they've had some contusion around the eye. They're in a lot of pain. They can't see. If you can open the eye to check the pupils, they may have an afferent pupil defect. So it's the pupils dilated, as opposed to a relative afferent pupil defect, which you pick up with this swinging light test. They can't move their eyes. The important thing is, without even giving them an anesthetic, is to perform a lateral canthotomy. And that means basically taking a pair of scissors and cutting the lateral canthal tendons, and that relieves the pressure and lets the eye come forward, and reduces the chances of them losing their sight. Ophthalmology is all pattern recognition. So we've got a picture here of a high femur, and that's a blood clot within the anterior chamber. And due to gravity, it sort of settles inferiorly, and you get this fluid level that you see on the left. And again, you have to make sure there's no other ocular injury. They can develop very high pressures. The treatment is bed rest, but when you're asleep, you've got rapid eye movements. I'm not sure that strict bed rest really achieves anything, but often these are children and you can't control them anyhow. On the right is what we call an 8-ball high femur, which is obviously more serious, more likely to cause pressure problems, but also you can get corneal staining from the blood with the high pressure, so you might need to evacuate the clot, but that's quite dangerous because often the iris comes out when you open up the eye. Blowout fractures. This could be a tennis ball or a fist, and when that hits the eye, it pushes it back in the socket, and the weakest parts of these orbital walls give way, and that's usually the floor and the medial aspect. And the ocular muscles get trapped in the fracture, and the patient has problems with motility. So this chap is trying to look up. His right eye can do it, but the left eye is stuck. So that's a problem cosmetically and functionally. If they've got double vision in the primary position, then that's a nuisance. If it's just up gaze, it's a problem if you're a librarian or a snooker player, as they say. So this man had a head injury, and albeit it's a bit of a rare cause of eye problems, he was losing his sight. The lid was dropping down, but even when you lift it up, the vision was reduced. And he had proptosis. You can see that the eye's coming forward, but also you can see that the blood vessels here are what's become arterialized. So they're all convoluted because there's high pressure within the orbital circulation, and he had a caroticocavernous fistula, a direct one. So he needed radiological intervention to seal off the fistula, which they coiled. This is a lid trauma. This in itself won't cause blindness, but you want to make sure there are no other injuries. The fact that it's involving the lid margin is important because you've got to repair it carefully in layers, otherwise you end up with a notch, and then the patient has a disfigured eyelid, but also the eye may water as a result. Can you see what's wrong with this eye? This is an iris dialysis. So the lower part, the iris root has been disinserted. And that can be repaired surgically, but it can also, because the aqueous drains in this area through the trabecular meshwork, that may cause glaucoma in the future.
Can I just ask quickly, sorry, what kind of injury would cause? Blunt
trauma.
Just blunt trauma, okay.
For the iris injury, the dialysis.
Yeah.
Now, that's right. And now this is more direct trauma. So obviously you can see the iris prolapsing through a corneal wound on the left. Now that may be quite subtle, and the clue may only be that the pupil is dragged in one direction. That's a full thickness laceration that may have happened from an assault like a bottling. Sometimes it's quite innocuous. So this is an intraocular foreign body on the retina. And this was a patient who was playing golf, and he got his ball in the bunker, and when he was hitting it with his sand iron, it hit a stone and some of it flew off and penetrated his eye. More often you see these things in people doing DIY, and they're not wearing safety goggles and they're doing drilling. And you've got to have a very high index of suspicion for intraocular trauma like this. An intraocular foreign body can cause infection as well as direct trauma to the eye. And if you suspect this from the history, you need to get x-rays because most metallic bodies will show up on the x-ray. And if you ask the radiographer to do it with the patient looking up and down, if the foreign body moves when they're doing the different eye movement positions, then it tells you that it's intraocular. Obviously, you can do a CT scan, but an X-ray will pick it up as well as thorough clinical examination. This is a more serious injury, and you won't have any difficulty diagnosing it. These are typical patients who've been assaulted with a bottle and the eye has suffered pretty awful injury. And often you're just trying to save the structure of the eye, because often the contents will come out through such a big wound as that. When you see that type of patient in casualty, the one thing you mustn't do is put any antibiotic ointment into the eye. Just put some anesthetic drops if necessary, and put a shield over the eye and wait until the ophthalmologist comes. Chemical injuries. Do you know about these? What's the first thing you must do? Irrigate.
Rinse with water. Yeah.
So yeah, rinse with water. If it's at home, whatever, just put the head under the tap. If they come into casualty, just get some saline and run it from a drip over the eye, a couple of liters. But you should test the pH until it becomes neutral. The problem is, for the patient, is it acid or alkali? Does anyone know which is worse?
Alkali.
Alkali.
Yeah. Okay, alkali is correct. The thing is, acid precipitates and doesn't go any further, but alkali, it's like ammonia injuries, they just permeate through the cornea and cause much more devastating damage to the eye. When you see that, it could be something like plasterboard. When people doing plastering, you get plaster, that's alkali, and you need to irrigate it and turn the lids over, invert the lids, and wipe off any alkali deposits with a cotton bud. We need to see them because there can be long-lasting effects on the cornea. The stem cells that regenerate the cornea can get damaged, and you get limbal ischemia, and the cornea packs up. So we treat them with antibiotics and steroids. They may get a pressure rise, so we have to treat that. Also, vitamin C, there are very high levels of that in the anterior chamber, and they get depleted in chemical injury, so we give them oral vitamin C and ascorbic acid drops. But that's a very serious problem. Now I'm going to talk about iritis. This can be quite mild, and patients have recurrent attacks, and you need a slit lamp to see cells within the anterior chamber. But often, if they've had multiple attacks, it's obvious what's going on. So in this slide here, the pupil is all stuck down because of previous iritis. So that's called posterior synechia. And if that happens 360 degrees, then you can get iris bombay, where there's aqueous produced behind the iris, and it all balloons forward and seals off the angle, and the pressure goes very high. The other clue to the diagnosis are these keratic precipitates, KP. So these are the white dots on the inside of the cornea, on the endothelium. If you've got something like ankylosing spondylitis, which is associated strongly with iritis, then the keratic precipitates are very fine, and you need a slit lamp to see them. But mutton fat KPs, which you see with granulomatous diseases such as TB and sarcoidosis, are sometimes visible with the naked eye. You may also see a hypopion, which is a collection of white blood cells like a hyphema at 6 o'clock, and that's a sign of intense inflammation. Iritis most of the time has no underlying cause, but if patients are having recurrent attacks, then you can do investigations and see if they're HLA-B27 positive, or they run tests for sarcoidosis, etc. But more often than not, there's no underlying cause. One of the important tips that I can give you is to look at how the eye is injected. How is the hyperemia arranged? So if you've got diffuse injection of the conjunctiva, like in conjunctivitis, it's all over the place. Whereas if it's an intraocular problem, it's called circumcorneal or circumlimbal, and it's around the edge of the cornea. And that may be a sign of keratitis, iritis, or acute glaucoma. So if you pick that up, then it's a good tip to work out what's going on. So we've got a patient who wears contact lenses and comes in to casualty and says, I can't see, it's been painful for a day or two. I took my contact lens out, but I'm very worried. What do you see here? If you had to refer this patient to the ophthalmologist, what signs can you tell him or her? Is Labib going to tell me something? I'm sorry to pick on you.
Oh, that's okay. You can see the conjunctiva is quite obviously sort of inflamed and almost bloodshot.
Yeah. What about the white thing at 6 o'clock on the eye?
Or corneal ulcer. There's some sort of cloudiness over.
Yeah. So yes. So in the middle, there's a very large corneal ulcer, and so that's infectious keratitis. That's an abscess within the cornea, and then at 6 o'clock is a hypopion. So that's a lot of pus within the anterior chamber. So that patient needs urgent referral. We would do a scrape of the corneal surface for an urgent gram stain and culture and sensitivity, and start them on intensive drops every hour for 48 hours, sort of day and night. If they're sensible, they can do it at home, otherwise they get admitted. And that's Pseudomonas is one of the things that we worry about most of the time. It's usually seen in contact lens wearers who have got poor hygiene. We used to see a lot of it in the past, but now people wear daily disposable contact lenses. It's less a problem because the risk of infection is much reduced. Right, another case. So this patient feels a lot, really unwell, been vomiting, vision's blurred, they've got pain. What can you see here? So you've got a slightly dilated pupil, it's oval, and when you shine the light on it, it doesn't react. And the cornea is cloudy. This is acute glaucoma, so the patient might have had halos preceding this, but not everyone gets these warning symptoms. And this will happen in elderly patients who are long-sighted. They've got a small eye, and as you get older, your lens becomes a cataract and increases in size and pushes everything forward. And basically you get a blockage of the angle, so the fluid can't get out through the trabecular meshwork, and the pressure builds up. You may get subacute attacks, which sort of abate when the patient falls asleep, but then you get this final attack that causes incredible pain, vomiting. The problem here on the right is that the anterior chamber is very shallow, so you've got the white line is the corneal reflex, and then behind it is the iris. There's no space in the anterior chamber. And when you check the pressure, it's sort of in the region of 60, 70 millimeters of mercury. Normal's up to 21. But you can do this digitally, and as I said before, and work out that there's high pressure. I've seen twice patients go to general surgeons thinking they've got an acute abdomen because they've been vomiting and they've got dehydrated and it's only the next day that someone notices that this patient's got a red eye, and that's the cause. Obviously, that's unusual, but it does happen. So be wary of the patient vomiting. It might be acute glaucoma. This patient's complaining of foreign body sensation and blurring of vision. And you put some fluorescein in. What do you see there? Is it an abrasion or is it something more?
Seems to be a fluid level at the bottom, and then there's also a sort of tear or something at the superior aspect.
Right, yeah, that's just the tear films. This is what happens to patients in eye clinics. They come out with yellow eyes because we're putting fluorescein in all the time. This is a dendritic pattern. So this is herpes simplex keratitis. And if you look close up, you get these buttons. That's the sort of pathognomonic feature on the slit lamp. It could be an abrasion that's healing, but if you see the buttons or if they've lost corneal sensation, that goes with viral infections. So these patients need ganciclovir ointment. The worst thing you can do is give them steroids, because then the virus goes berserk and you can get a geographic corneal ulcer and terrible scarring of the cornea. One thing you need to be wary of is endophthalmitis, which is one of our major emergencies. So this usually is after surgery, such as cataract surgery or intravitreal injection for macular degeneration. And the patient typically will say, I had very good vision to start with, and then the eye became painful and my vision became more blurred, and that happens usually within the first 48 to 72 hours. Occasionally it can be endogenous with patients with septicemia, and sometimes we see patients on ITU who get candida infection from their intravenous lines, and it migrates to the eye. In the early stages, you may see retinal infiltrates, which is the top slide. The slide on the right shows a small hypopyon, and the eye is very red. You wouldn't normally see a red eye like that after cataract surgery. And then when you dilate the pupil, you see a lot of junk, vitreous opacities. And these patients need urgent admission, and we take a sample of vitreous and then inject intravitreal antibiotics. Moving on, we've got a patient who says, I can't see so well now. I had some flashing lights, floaters, and a shadow. And those are the symptoms of a retinal detachment. Now, that's a retinal detachment. The retina becomes sort of folded with a corrugated, wrinkled appearance because there's fluid underneath. You need fairly sophisticated equipment to diagnose this. If it's very big, you may pick it up with a direct ophthalmoscope. This is a retinal tear. It's a large, they are what we call horseshoe tears. And there's traction on the lip of the tear, and then the fluid gets in underneath and lifts it off like sort of a bubble under wallpaper. The story with a retinal detachment is that as you get older, the vitreous gel, the jelly, contracts and separates. And if there are abnormal adhesions to the retina, it can pull and cause a tear. And if it pulls on over a blood vessel, you may get a vitreous hemorrhage at the same time. So patients will have symptoms of flashing light because of traction from the vitreous pulling on the retina. They also get floaters, which may be due to vitreous hemorrhage or condensations within the vitreous jelly. And then if the retina detaches, they talk about having a shadow come across their vision. Sometimes they say it's like the veins of a leaf, and it's because the veins on the retina are coming away. And patients with flashing lights and floaters, you want to see them early without delay, because if you pick up a tear, then you can laser it and reduce the chances of them having sight-threatening retinal detachment. So viral retinitis is fairly uncommon, but we've seen more of it. We used to see a lot with AIDS patients with CMV retinitis, but now we see it in patients who get shingles. What you see in the early stages are sort of peripheral infiltrates in the retina and a lot of vitreous haze, a few hemorrhages, and then it can progress to this picture, which it has a few names to it. Pizza pie retina or cottage cheese and ketchup. The cottage cheese is the white infiltrate, and then the ketchup is the hemorrhaging on it, on the surface of that. A few more diagnostic challenges. This patient says they suddenly lost their vision, and when you dilate the pupil, you can see that retina doesn't change. The lower half appears pale. Does anyone know what that might be? That white retina.
Artery occlusion.
Artery occlusion, correct. Just in time. So that's very good. And then this one. This is a vein. Yeah, correct. So when the central retinal vein is blocked, the blood can't drain out and it sort of bursts out onto the retina. And you see a whole variety of hemorrhages, flame-shaped. So the ones by the superior arcade, and then you get blot hemorrhages, which are deep in the retina. And also you get these white cotton wool spots. That's a branch retinal vein occlusion on the left. And you can also get swelling, a swollen optic disc with this, with a vein occlusion. So with vein occlusions, it's really a medical event. They're most often consequence of atherosclerosis. So you want to check whether the patient's hypertensive, diabetic, their lipids. They may have myeloma, so you do screens for that. Glaucoma is associated with vein occlusions, and also external compression on the eye, such as thyroid eye disease or a tumor, less commonly. This is sudden loss of vision due to an artery occlusion, and this is the cherry red spot in the center. So you've got the optic disc on your right, and that cherry red spot is where the fovea is. The retina's at its thinnest there, but elsewhere it's all white due to swelling. And a central retinal artery occlusion, this is pretty devastating. The patient's almost certainly going to be blind. If it's less than 6 hours, you might be able to get some vision back. You want to lower the pressure and encourage circulation, and that means giving them cetazolamide, massage the eye. You may even stick an orange needle in the anterior chamber and let some fluid off. I've only seen it work once, and that was when a husband of one of our nurses developed it, and she brought him in straight away. You've got to make sure that there aren't other underlying causes apart from hypertension. Something like giant cell arteritis may cause this, so you need to do an ESR urgently. Macular degeneration, usually this will present to the optometrist, but it may turn up in casualty. And the symptoms are distortion. Patients can't recognize faces, they can't read. Patients with pre-existing macular degeneration are given this Amsler grid, which is a sort of graph paper, they're asked to monitor it either daily or weekly, looking for change. And there are two types of macular degeneration. The dry type, when it's just an atrophy over the macula. The wet type is due to bleeding or leakage of fluid, and that's the one that we can treat with injections. The underlying cause is blood vessels that leak, and this is a fluorescein angiogram showing the leaking blood vessels within the hemorrhage, but we can diagnose it more quickly with a scan, an OCT scan, which shows the blood and the membrane there. And we treat it with intravitreal anti-VEGF agents such as Lucentis. We're doing this non-stop. It's unbelievable how many patients need this treatment, and it's done repeatedly every 4 to 6 weeks. And there is a risk of endophthalmitis, so you may see a patient who suddenly lost their vision after an injection the day before. Going on to more medical problems, diabetes is usually a more gradual loss of vision, but if they have new vessels growing on the retina, those can bleed, and then they suddenly lose the vision without any symptoms beforehand, and they can't see anything and you can't see anything. When you try to look in and get the red reflex, if the vitreous is full of blood, you don't see anything. So it's a sort of diagnosis by exclusion. Obviously, we're used to seeing it, and we can do ultrasounds in the clinic to confirm it and check that there isn't a retinal detachment behind it. Headache, with new onset headache with jaw claudication, pain on chewing, often in the background of a polymyalgia symptoms and fever. You need to think about giant cell arteritis. And then pain on eye movements, then that may be a young woman with optic neuritis and demyelination. So temporal arteritis, a few words on that. Do you know what type of field defect you would get with temporal arteritis? Usually they lose either the upper half or lower half of the vision. If you get a problem with the optic nerve, it's altitudinal, either up or top or bottom, similar with a vein occlusion. Whereas if it's something more behind the chiasm, then it's like a bitemporal hemianopia with pituitary tumor or homonymous hemianopia with a stroke. So when you see a patient with sudden loss of vision, they have a pupil defect, they'll reduce color vision, they may be missing half the upper field or the lower field. And then when you look into the optic nerve, it's swollen with hemorrhages around it. And it could be either non-arteritic or arteritic. So we call that NAION, ischemic optic neuropathy, or arteritic. Arteritic is giant cell arteritis. Non-arteritic, it's usually a small crowded disc, and their patient's got hypertension or diabetes. Those are the other risk factors that compromise the circulation. Giant cell arteritis, they may have polymyalgia as well. Obviously, the investigations for giant cell arteritis are an ESR, CRP, full blood count looking for increased platelets, and a temporal artery biopsy. But you don't wait for that biopsy. You start them on high-dose steroids, milligram per kilogram body weight. You can diagnose it with an ultrasound, but not every department can provide that facility. Giant cell arteritis is rare under the age of 50. Demyelination, multiple sclerosis, the classical symptom is pain on eye movement, blurring of central vision, and reduced color vision. The colors are washed out, and if you have an Ishihara color vision chart, the patient doesn't see many of the color plates. It can be mild, but sometimes patients have very profound visual loss with optic neuritis. They may have some eye movement abnormalities from demyelination and causing an internuclear ophthalmoplegia. And they may have had that in the past. I'm pressing on now. Amaurosis fugax. I think Labib was talking about this one beforehand. So this is like a TIA and needs a medical workup. Occasionally, you look in the retinal circulation and you see emboli within the arterial circulation. Quite common is ocular migraine. And this is just like a typical migraine, but you don't get the headache. You get a scintillating scotoma with sort of zigzag lines. And then usually there's a central blur that moves outwards, and it can affect patients for a few minutes, and then it all subsides, sometimes a bit longer. This is a complicated slide to finish on. It's just to show you the visual pathways and the field defects that you'll get. Some patients with a stroke will say they've lost the vision in one eye, but they haven't really worked out covering up one eye and then the other, that it's missing in both. And so they may have a sort of right homonymous hemianopia. And you can diagnose this really just doing confrontation feels with your hand. It will suddenly disappear when you go into their blind area. Very rarely you can get an occipital lobe stroke, which just takes out the macular fibers and the patient can't read. So that's number 11. So I think that's the summary. Are there any questions? I can't hear you. Labib, were you saying something or no?
Quiet.
Quiet silence. Okay.
Thank you
All right.
very much for teaching.
That's all right. I hope it's been helpful.
Thank you.